Hi, this is Birgit from the non-profit organization Krank Durch Brustimplantate in Germany again. And my guest today is Dr. Shaher Khan from Michigan, USA. Hello, Dr. Khan.
Yes, hi. Good afternoon and good to talk to you. And always a pleasure to discuss breast implant illness with any of my colleagues.
Yeah, thank you very much. So nice to have you here as my guest.
Likewise.
First of all, I want to thank you that you are willing to answer my questions today. I have been
Yes, you're welcome. No, it's always, I want to jump in and say, whenever anyone wants to talk about breast implant illness, I want to take the opportunity to very nicely, professionally raise awareness in a very nice, systematic, assertive way so that we pass on hard information. I cannot remember that I have said no to anyone who has asked me for any podcast.
That's
or
very,
any
very
interview.
nice. Yeah, thank you so much. It's so important. It's so important, Dr. Khan. So I have been following your social media channels for a long time now, and I listen to almost all of your videos and podcasts as well. So recently, a member of our German community has been your patient for removing of her residual capsules. But before I start questioning Dr. Khan, may I kindly ask you to introduce yourself shortly to our audience?
Yes, I am Shaher W. Khan. I'm a board certified plastic surgeon. I have done my general surgery training 5 years, where I've taken care of a lot of patients with breast cancer, mastectomies, lumpectomies. In this training, I also did 2 years of burns and critical care, and then followed by 3 years of plastic surgery training, a total of 10 years after medical school. My practice is exclusively devoted to removal of saline implants, silicone implants, and residual capsules. And I'm humbled to say that I have only put in one set of implants in order to get board certified, and I choose purposefully, deliberately to not put in implants because I did not want to do any harm.
That's fantastic. Thank you. Thank you so much. So that was my next question. You are not implanting. So how many explantations have you done so far? So roundabout. And what is your en bloc rate? Can you say that?
Yes, please. So I have only been explanting, and especially with the many patients that have come to me for other plastic surgery procedures. And so I've only done one augmentation. Now, as when it comes to the explants, this is a very good question. Last year in May of 2023, I presented my 1,000 explants at the Icoplast conference ever since I started counting the number of explants that I was doing. Remember, I do anywhere from 6 to 9 of these in a week, and my practice is exclusively devoted to removal of implants. So I would say, just a rough estimate, it'd probably be in the 2,000, 2,500 range. Now, I will tell you, it's not more about the numbers per se, but also importantly about the technique. Because if another surgeon has done, let's say, 3,000, but he's doing an explant and a lift in 3 hours, that I would say is physically impossible in my practice. And what is interesting is if you talk to 10 different plastic surgeons, you are going to come up with 10 different answers, 10 different techniques, 10 different thought processes. And within the patient groups themselves, the surgeons may have variations within their scope of practice. Now, as when it comes to en bloc, the en bloc word is I use the word, not the precise perfect word, but this is a word that basically tells the other reader and listener and the other surgeons that there was no break in the capsule where their entire implant and capsule was removed. For example, if someone had a ruptured implant, you want to do it in en bloc such that none of this silicone spills into the chest. The term total capsulectomy is then the word to use if there is a break in the capsule. Say, for example, the capsule was tightly adherent to the rib, then that inevitable break occurs in that capsule, and now an en bloc did not happen, but a total capsulectomy happened. So for my listeners, I would say roughly 30% to 40% of my cases are what are en blocs. Now, on a patient, for example, I did a 100% total capsulectomy on the left. I may have done an en bloc on the right. The most important thing is that even though a total capsulectomy was done, that is 100% total capsulectomy, none of that silicone spilled into the chest, that it was contained. And normally what I do is I dissect all the way around, and indeed what is the hardest part of the surgery is where that capsule is stuck, super glued to the rib. I leave that part to the very end. And so that if there is a break, I'm able to put a 4x4 gauze, I'm able to suction, or I'm able to put a barrier such that I'm able to automatically clog that break in the capsule. So even though this was not a true end block, the word total capsulectomy, 100% total capsulectomy was done, and there was no capsule left behind. And one of the ways to attest to the fact that the total capsulectomy was done or there was no spillage into the chest is the reason that I don't use the drains. It's been well over 5 years that I have not used drains because there was no capsule left behind. There was no spillage of the silicone. There was no cauterization of the capsule, which means burning of the capsule. Now, in those situations where the surgery was rushed or the capsule was left behind or the silica spilled into the chest, then the drain usage becomes mandatory because that residual inflamed tissue will now cause more of that fluid to build up. And as you will see, majority of the surgeons are not putting in capsule the drains not only for 1 week, 2 weeks, but 3, 4, up to even 6 weeks later, which is very surprising that that would be required. And if I may mention, when I presented last year at the ICOPLAST, which is the International Plastic Surgery Conference, actually the largest conference in the world of plastic surgeons, which is all reputable board-certified plastic surgeons were there. I presented my 1,000 explants. I mentioned clearly that the drains are not required and that the surgery can be safely done when all of that inflamed tissue is removed, the capsular tissue is removed, and no spillage of the silicone, the drain usage is not needed.
Okay, so you answered almost all my questions now, so thanks a lot. So you were just talking about it. What is the Krank procedure? So that was my next question, and you just described it. So can you just repeat it in a short way? What is the Krank procedure? What describes it?
Yes. So Krank procedure is because I do these systematically from one patient to the next, I want to be standardized and very thorough. So number one, no need for the unnecessary drain. Number two, no need for the unnecessary lift. Number three, the capsules are always sent to pathology to rule out the BIA-LCL, rule out the BIA-SCC, which is the breast implant associated, squamous cell cancer, breast cancer, any abnormal pathology. And then number four, cultures are done for aerobic, anaerobic, and fungal. Number five, I do high definition pictures and videos of the chest wall showing complete removal of the capsule and all inflamed tissue. And also me cutting open of the capsule on the table. Number six, twilight sedation, which means that the patients get the propofol, fentanyl, Versed. They are not paralyzed and they do not have a breathing tube and a ventilator breathing for them. I have what is the twilight sedation, where the patient is in deep coma and sedation, and they have no recollection of the surgery. And number seven, all the patients more or less get the same the surgery regardless of their comorbidities. So for example, if someone is a little bit on the obese side or they have, quote, a stent in their heart, I will go to the hospital and do the surgery in the same manner like I would do a patient who is in her 30s. And so this is where I've consistently done the surgery where the patients benefit from total capsule removal. And this is what I have said, no matter how thin the capsule, the 100-0 rule. 100% of the time, 100% of the capsule is removed with 0% of the capsule remaining behind.
Is it also possible in any case if there was a breast cancer before to remove any part of the capsule?
Breast cancer?
Yeah, if there was, if a woman had silicone implants after mastectomy and then she gets an explantation, is it always possible then to remove any part of the capsule as well?
Yes. So the capsule has to be removed, no matter how thin. or how involved or how adherent it is to the rib, that entire capsule must be removed. So in my practice, as you will see, please go to the YouTube page or the Facebook page. When I remove the capsule, in majority of the cases where the implant is below the muscle, when I remove the capsule, I incorporate the fascia of the pectoralis minor, the fascia of the serratus anterior muscle, the fascia of the intercostal muscle. I also incorporate the periosteum and the perichondrium. That ensures for me that the whole capsule is removed completely, definitively, sincerely, because remember, this is where that recovery lies. The patient's post-operative recovery is dependent on me completely, sincerely removing the whole capsule. And like I was saying earlier, it is inadequate, wrong, improper to leave that capsule behind because it was too thin or because it was too hard or it was too risky. The surgeon has to be determined, motivated, convinced that that whole capsule must go. Anyone can remove the implants, but it's all about that capsule, such that post-operatively the patient has the peace of mind, that confidence that all of that was removed and that it was tested for pathology and also for cultures.
Okay, thank you very much.
You're
So,
welcome.
you just mentioned it. One part of the CAM procedure is not only to remove the implants and also the capsule tissue, but also all inflamed tissue. And this is different. So, what does that mean? Could you please explain that to our audience in an easy way? And does the removing of tissue or inflamed tissue change the breast shape or volume?
Very, very good and thorough question. So, if you look at the histology that is under the microscope of the capsule, you will see there is that capsular tissue, that scar tissue, if you will, that forms around any foreign body, be it a screw, be it like a port for chemotherapy. And now what happens is, as you know, this phenomenon of gel bleed, where the gel leaches out into the periphery, even with saline implants and certainly silicone implants, and certainly very much so with ruptured silicone implants. So now that capsule is trying to accommodate and hold and be a barrier for that silicone to leach out. So we know from the many pathology reports the tissue around the capsule can get inflamed. There's been reports of silica embedded within that tissue, fatty tissue, inflamed tissue. You see giant cells, histiocytic cells. You see inflammatory cells, foamy macrophages. You see non-polarizable material consistent with silica within that soft tissue around the capsule. So it is imperative on a gross level when the surgeon is dissecting that anything that is hard, abnormal, be it an abnormal lymph node in the path of the dissection or any tissue that is of different color consistency like dark brown or gray, that needs to be removed along with the capsule because that has in it the impurities and the toxicities that the pathology samples have mentioned. So you will see in many of these ruptured implants, for example, it's not clean cut, simple capsule, but that inflamed tissue around the capsule that's also incorporated so that that gives the patient the best chance for recovery rather than just the capsule alone. Because the capsule in itself is just scar tissue. And what I will do in order to answer your question, I will show histology slides from one of the plastic surgery slash oncology groups out of the Memorial Sloan Kettering, where they looked at the histology, the under the microscope, the capsular tissue. You will see that there is chronic inflammation outside of the capsule that must be clearly incorporated. So in my case, I always incorporate that so that I do not want to look back and say, I wish I had removed more. Remember, anything abnormal, looks abnormal, feels abnormal, palpates abnormal, and sixth sense tells me that is abnormal, I remove it. Now, I am extremely careful. In majority of the cases, the breast tissue is above the muscle, which I do not touch. The entire inflammation and the fatty tissue and whatnot else is around that capsule and implant is below the muscle. So I dare not go into the breast tissue. I dare not remove the breast tissue. That is precious volume. I certainly do remove that excess skin. I remove the
Okay.
inflamed fatty tissue that's around because I do not want to compromise the volume for the patient.
Okay, I understand that. Now I understand it.
Yeah,
Thanks again.
you're
So,
welcome.
you were talking about the pathology and the capsules. So, concerning the CD30 test, concerning BIA-ALCL, I'm interested in the following. Do you recommend that test in any case of textured implants, or only if you find something suspicious or in case of special symptoms?
So this is a very good question. Now, this is exactly very similar to the head of the pathology department at the major hospital right across from us, Trinity, a major hospital system of the state of Michigan. So this is a very similar discussion he and I had. So when I told him, when I moved to this new location, I reached out to him and I said, I want a CD30 analysis on every patient. He actually called me and he and I had a discussion and he said, well, that's overkill because that's going to be relatively more expensive and it is going to be too much. And sometimes the insurance companies might just outright deny. I said, you have a valid point. I said, number one, if you are the president of the United States and you're getting this explant done, and would you not want to get CD30 analysis? He said, sure, because we do everything by the book. Now, I said to him, are there any situations where you were to look at the capsule and because you did not do let's say you do 1,000 capsule analyses under the microscope, and because you did not do the CD30 analysis, would you miss BIALCL or precursor in some situations because you did not do the appropriate staining? He said, yes, because I cannot, otherwise, we won't need to do the CD30. And I said, that's my point. It's not exaggerated, but it is very appropriate. If I have my capsules removed, I want to get the complete test, even though it's an added cost. And that's why you will see the pathologist write down, Dr. Khan requested CD30 analysis, and we did it. And I said, thank you very much for spelling my name out because now we don't want a surprise, years later that there was potential precursor to BILCL. Now look at the hard facts. Let's look at the black box warning by the FDA. They say breast implant associated, which is BIAALCL, which means that the patient had no implants, then the BIALCL would not have happened. That means it's directly related. Had the patient had no implants, she would not have had the lymphoma. So the BIALCL is strictly directly related to the implant. So it's a direct correlation, not like a supposition. So had the patient had no implants, she would not have had the BIALCL. So they said this, and look at the verbiage and the language by the FDA. They said breast implant, BIALCL, breast implant associated anaplastic large cell lymphoma is more associated with textured implants than smooth, even though it's not at the same rate as textured. So that means what? That means patients who have smooth saline and smooth silicone implants also have association with BIALCL, but to a much lesser extent. How much we do not know. And this is the take-home message for the many plastic surgeons and the doctors. The manufacturers and the FDA and the plastic surgery societies will accept the fact to date there have been only 1,233 plus minus reported cases of BILCL, which is underreported because number one,
Yeah,
majority of the plastic surgeons are not removing them. Number two, even if they're removing them, they're not sending it off to pathology. And number three, even when they're sending it off to pathology, they're not doing the CD30 analysis. And now that's why it's underreported.
yeah.
The other thing that societies will mention that in the years to come, in the next 1, 2, 3, 5 years, the number of rates of BIALCL are going to only go up now that there is more and more awareness. And I totally agree with that because now more and more awareness is being made. And this is what I say, anytime any tissue is removed from the body, be it during a tummy tuck and more so during the explant, that this capsule must be sent to pathology to have the peace of mind that there are going to be no lymphoma, no breast cancer, there is no BIA, SDC. Now, remember, believe it or not, there are other cancers that are associated that have not even been highlighted. Now, I want to mention to the listeners that remember, BIALCL is very rare of rare of rare. There is no reason to lose sleep, but once anything is removed from the body, especially around the breast, it must be checked for breast
Yeah.
cancer. But
Yeah.
sure must be checked for any malignancy, any abnormal pathology, and even for these cells like the histiocytic cells, foamy macrophages, eosinophils, whatnot else, because that way you want to have closure that this was done, tested, and there are no surprises, and that they have the peace of mind moving forward.
Yeah, I'm in the same opinion. Absolutely. That's why I recommend it to every woman I talk to do the CD30 test. I mean, in Europe, I think around about 95% of women wear textured implants. So I always recommend to do the CD30 test in any case. And I know that many plastic surgeons here wonder about that. But
No, I will tell you, this is a no-brainer. This is, if anyone hears my argument slash discussion or my pros versus cons, I will tell you, if I am the patient, I want my CD. What's the cost? A few $100 extra,
yeah, yeah.
but it's all for the peace of mind. Look, we spend tens of thousands of dollars on cars,
You
vacation,
are
watch.
right. Yes.
Don't tell me you're not going to spend a
Yes.
couple $100 for what is real. And remember, it's underreported, and we want to
Yeah.
have that. We want to be complete. We want to be thorough.
Yeah.
We
Yeah.
want to be thorough.
Yeah, you're right. We support 15 women now with a diagnosed BIALCL at the moment. So they
Wow.
are 15 too much. So, yeah. Yeah, okay. So another question to you, Dr. Khan. If you know before surgery that you have to remove a ruptured implant, do you have another or a special technique to avoid spillage of free silicone, or is it always the same technique you use?
So whenever I go into any surgery, I think it is ruptured. Because remember, there is this phenomenon called silent rupture, which means if you examine a lady, her exam is A plus, no problems. And this has happened many times where the patient is showing no sign symptoms. So this happened like 6 weeks ago. A lady came in and I asked her, why do you want your implants removed? And she said, well, I heard 10 to 15 years and mine are at the 12-year mark. I would rather take care of it now than later. And her exam was unremarkable. And the next thing you know, I go in, the left side was ruptured. And to my surprise and to her surprise. So the plastic surgeon has to always go into the surgery thinking both of them are ruptured, even if there is an MRI that shows no, because you don't want to be caught off guard. Last Thursday, I did a case of a lady where it was not ruptured, but there was fluid around the implant and it was that end block, and none of this fluid leaked out. So the surgeon has to always think it's ruptured till proven otherwise, because you don't want to be caught off guard and in the middle of surgery, and now you have to deal with silicone inside the chest, which that is a catastrophe to manage. So now so what I do is I take my time. I take millimeter by millimeter, very tedious, meticulous dissection. The blood loss in well over 99.5% of my patients is less than 5 cc's. I remove all of that inflamed tissue. I remove all of that tissue that is inflamed, abnormal, looks abnormal, feels abnormal, palpates abnormal, my gut telling me abnormal, so that there is no, and even in those situations, like I mentioned earlier, and I'm dissecting off of the rib and there is an inevitable break, I majority of the times use what is a rate tack or a sponge in order to plug that in. Sometimes I have used suture in order to reinforce and tie that capsule off such that there is no break. Sometimes I have even used a suction device in order to pull all of that in an aseptor such that none of the silicone, because the last thing anyone wants is that silicone to spill into the chest. And all of that inflamed tissue, including the capsule and the inflamed tissue around, is removed completely, sincerely, in a very thoughtful, systematic, precise way, such that all of that is removed is sincerely. And this is the whole essence and gist of plastic surgery.
Thank you. I understand. So I heard that you don't remove lymph nodes, you don't do lipofillings, and this is very different. And you do not recommend lifts during explantation. Why not? What are your thoughts about that, Dr. Khan?
Sure. So this is a very good question. Now, majority of the lymph nodes, if you look at the pathology and the anatomy, are in the axillary armpit area. Now, if you or I start removing those lymph nodes, the patient is going to get lymphedema. That's a major problem because remember, the inflammation is going to spread. Now, in that patient that has breast cancer and the cancer has spread to the lymph nodes, it's absolutely a no-brainer to remove those lymph nodes for staging purposes and for oncologic reasons. So we will take that lymphatic, i.e., the arm with lymphatic swelling any time of the day over cancer. Now, if I'm dissecting and if I run into a lymph node in the path of my dissection, because that lymph node happens to be right next to that capsule, I will remove it from a cancer perspective and from a oncologic perspective because it's not normal to have pathologic lymph nodes. Now, the second question about the lipofillings. Lipo means fat and fillings mean fat transfer or fat grafting. Now, let's talk about this very serious matter. If someone takes fat, let's say 150 cc's of fat, and they liposuction, and then they inject fat into and around the breast tissue, easily a third of the fat is going to die. Some of it is going to form clumps of dead fat. And sometimes there may be acute and chronic pain. So post-operatively, if the patient is doing a self-monthly breast exam or they get a mammogram, and remember in the United States, 1 out of 8 or 9 women are going to get breast cancer, and now they're feeling their chest breast tissue, they're going to feel these clumps of dead fat and this pain, and now their exam is altered. They're going to say, is it fat transfer necrosis? Is this lumps of dead fat? Is it the fat that took? And now an unnecessary biopsy is going to happen. And I will tell you, no matter how good a surgeon you are, fat necrosis, fat abscess, fat problems occur. And I will tell you, I have gone as far as to say very comfortably, this is malpractice because now you're obscuring an exam, you're affecting the mammogram, and now you're putting undue anxiety, undue biopsies on a patient in the name of aesthetics. Which is more important, aesthetics or to do surveillance for breast cancer? Now, fat transfer to the face, excellent idea, A plus, I encourage it because the best applied to the body is on the face, and you do it 5, 10, 15 cc's. This is a permanent take, and the patient overall do good, but not on that breast. And I'll tell you for the same reason, I will today, as far as go, this BBL, Brazilian butt lift is something, it is, I use the word horrible surgery, unprofessional surgery. If you ask me, this had one of the highest rates of mortality in the United States in young ladies who are literally getting fat emboli to the lungs. This is something look, I did 10 years of training, day and night, 80 to 120 hours a week. After all that training, I'm going to go in and make a mockery out of a lady by putting it fat transfer because she wants it. I will tell you that is wrong, and it should not be done, and it should not be frowned upon. It should be, quote, not allowed. And it is not professional. It is essentially, in my mind's and eyes, making a mockery of the human body, and it should not be justifiable, even though the patients request it. And, sometimes I say this to the patients very objectively. Just because the patient wants it, the surgeon should step up and say, I would not recommend something that could be potentially life-threatening and something not healthy, not wise. If you ask majority of those patients, when they sit, they don't sit as comfortably as they did before, and it only leads to more problems and more hurt eventually. And when they get older, they will realize they did disservice to their body.
Okay. And what about the lift?
Yes. So remember, majority of the times that the implants are placed below the muscle. Now, with the inflammation subsiding, with the weight of the implant that's pulling the breast tissue down, with the recoil of the skin and the breast tissue that can occur 20, 30, 40%, with the excess skin that I remove, with that internal sutures that I placed that cause a pseudo lift, and number 6, between the working out where that adds 5, 10, 15% muscle mass to the chest. Majority of the patients, well over 80, do not need what is an unnecessary lift. Now, I just saw a patient in my clinic. She's 67. And she said, how am I going to look afterwards? I said, well, if I were to go to a group and I say, all the 67-year-old ladies, please come to me. How many of them would need a lift? I will tell you all 1,000 of them would need a lift, not only a breast lift, a face lift, a neck lift, a thigh lift. But because I can do it, should I offer it to them? And the answer is flat out no. Now, if they want it after the explant, now remember, my explant procedure takes almost plus minus 4 hours. Now, if this is an 800cc implant, it will take longer. When my patients are on the OR table, I do not want to do what is a 4-hour explant and then maybe a couple hours easily added on for a lift, because remember, that is a separate operation. Now, the history and research and science has shown once the patients are on the OR table past the 6 hours, the rate of DVT, the lung respiratory issues, wound dehiscence, infection problems go up significantly. And this is where, remember, if you go and see those patients that go overseas or to Mexico or to get, I got a tummy tuck, arm lift, thigh lift, augmentation, 12 hours, you see these patients, quote, every once in a while dropping dead simply because there was too much surgery done for convenience and financial sakes. The goal of the surgery is what? To remove the entire implant, capsule, inflamed tissue, and to do it sincerely, completely, definitively, with a good heart and good soul, good mind, and sincerely. And post-operatively, you will see 80% of my patients do not even need that unnecessary lift. And God forbid, let's say if you are that 20%, you may choose to not get one. Or if you do get one a year later so you can get the best lift possible. Because now the inflammation subsides, the patient has lost maybe 5, 10, 15 pounds, and then you can get the best lift if you want to, if you wish, but not at the same setting as the time of the explant, because that whole devotion needs to be done to doing the surgery right without any risks of complications. I've seen patients who came to me with nipple necrosis, wound dehiscence, chronic drains, a lift that was good, but guess what? The surgeon cauterized the capsule or incomplete removal of the capsule, and now the patients are running into problems.
Okay, I understand that. Okay,
So if a patient
thank
has a
you.
ruptured implant, you don't want to be doing a lift because that tissue is abnormal and angry, and it will hurt the patient to doing a lift.
Yeah, I understand that. Okay, thank you, Dr. Khan. So you were answering my questions concerning drains. So you said you seldom use drains, or you don't use them very often, and you prefer the twilight sedation. What is the difference? Can you just explain it shortly?
Sure.
The difference from twilight sedation to another one?
Yes, please. So this is a very good question. If you look at general anesthesia, for example, someone needs to get a colon resected. What is the difference between general and twilight deep sedation? So general sedation anesthesia is, general anesthesia, not general sedation. So general anesthesia is where someone needs to get their appendix out or gallbladder out, colon resection. The patient is paralyzed, and now the patient has a tube put down into the lung, and now the ventilator breathes for the patient. This happens every day in the United States and Canada, Europe, comfortably, safely, and the patients come out of this full anesthesia, if you will. Now, remember, when you paralyze the patient, there is a potential for getting clots in the leg. You have ventilator-associated problems, ventilator-associated barotrauma, there's tube problems, amongst others. Now, this is still relatively safe, done on kids and adults every day. I propose what is twilight or deep sedation and not the general anesthesia. I propose the twilight, where the patients have complete amnesia to the event. They have no breathing tube. They're not paralyzed, and they are basically given propofol, fentanyl, Versed, and they're in a deep coma or deep sedation where they're literally breathing through their surgery like they did the night before, but completely by chemicals. And now when they come out of the anesthesia, they're better. It's swift. And there is no quote trauma, if you will, as not when I use the word there is no effect of that general anesthesia. Their risk for clot is essentially non-existent. Now, this is always better, safer, nicer than the full general. Now, there are times where I was dissecting on a patient and she was relatively complicated at the hospital. I asked her to be paralyzed, and I did the general anesthesia. Now, remember, this is maybe a 5%, if less than on my patients, but the vast majority, well over 95%, is that deep, safe, very practical, effective anesthesia where the patient
Okay.
can recover, and none of them to date have had any recollection of the surgery.
Okay.
Now,
That's very
yeah, now the,
interesting. That's very
yeah. So this,
interesting.
yeah, and I tell all the plastic surgeons do it in this fashion. Believe it or not, I have had patients, their mom was like, or dad, they were in the medical field, or they were doctors, or husbands, and they understood, and they still said general anesthesia is certainly safe, but this is better, safer, more practical, and
Okay.
gets the job done. No patient is awake during any of my surgeries. That is wrong. That should not be done. We hear about patients getting an explant while they're fully awake. That is absolutely wrong.
Okay. Okay. So thank you for that explanation. I have to check if this is offered in Germany. I'm not sure about that. I have to ask the plastic surgeons I'm in contact with. So thank you
Yes.
for that.
Yes. Now,
So
you had a question about the drains. That was the first
yeah.
question. Now, believe it or not, yesterday, ironically, I talked to a lady from San Antonio, Texas, and her husband is an interventional radiologist, so IR. He's a full doctor, and his job is what? Drain placement. And in urology, ENT, vascular surgeons, plastics, and urology, OBGYN, this is his specialty. And I told him, why don't you come on as a guest and talk about drain placement? And this is what I said to earlier. When all of that inflamed tissue is removed, the bleeding is essentially minimal to none, 5 cc's, and the muscle is essentially left undisturbed, and all of that inflamed tissue is removed, and the blood loss is essentially minimal. You will see, and there's no spillage of the silicone into the chest. You will see the requirement for the drain is not there, to the point where the last time I used the drain was well over 5 years ago, even in the many patients who have had ruptured implants, who have had large implants, 800 cc, even when they have had significant inflammation. Remember, anywhere 20 cc's or less, the body in itself will absorb it. Now, I say to the many other plastic surgeons, why do you use drains? Because the burden is not on me, burden is on all those plastic surgeons who use the drains. When I presented my cases at the ICOPLAST, the largest international plastic surgery conference, I said, I don't use drains. Even in the 1200 cc largest implant that I've removed, I did not use drains because they're not required. And the burden is on all those plastic surgeons who are using drains. And I say this to you, if any of the capsules left behind, any of the inflamed tissues left behind, or there's any spillage of the silicone into the chest, that now causes inflammation and fluid buildup. And now the drains become mandatory. And you will see some of the surgeons use drains not only for 1, 2 weeks, 3 weeks, but up to 6 weeks, which is wrong, because remember, the drains themselves, just by having a drain in itself, will cause some fluid to build up. The drains, if that drain opens up, some of that fluid can backtrack into the chest, then can be a major catastrophe, because remember, that fluid is not sterile. Or the drain itself can dislodge in and out if that suture becomes loose, and that in itself can seed bacteria into the chest. So the drains themselves, I've placed many of drains for tummy tucks, for example, or other cases. But in an explant surgery, they clearly are not required. And if that was required, guess what? My patients themselves would be coming to me right and left and saying, "Doc, I need a drain. Doc, I need a drain." I would be, and I have none of that. In only that very small group of patients who are moving their arms about, they are not wearing the compression with the bra and binder, or they are basically doing exercises. Then you will induce seroma formation. Just like after a tummy tuck, if they start doing sit-ups and moving around right and left and going up and down the stairs, you will see that seroma will inevitably occur. And in those some select patients who are non-compliant, unfortunately, this does occur. Now, in some situations where the patient had like 1100 cc implant and she had fat necrosis and implants above the muscle, and alloderm that was removed, there is a higher chance in obese patients to get a seroma, and in those cases, a drain would benefit,
Okay.
but not always. Yeah.
Yeah. Okay, I understand. So, Dr. Khan, we could talk about it for hours and hours, I think. There are so many other questions I could ask you, but as you are spreading awareness about BII and your techniques as a specialized explant surgeon regularly, we can find all your informations in your social media channels like Facebook or Instagram. So, I have some further questions concerning my German community. Maybe there is someone who wants to use you as explant surgeon in future. So how long do you have to stay close to your office until they can fly back home? What is
Sure. No,
needed?
this is yeah. So what I would say to you is I want the patients to have done their homework. And now I will say this broadly. You know, if someone gets the gallbladder removed, it is done in systematically the same way in California, in New York, Michigan, Texas, same way. When it comes to explantation, every surgeon has their own way technique. As you will see, we were never taught this in our training. Even today, this end bloc / total capsulectomy is only reserved for those patients who have the BIALCL. Now, every plastic surgeon, be it in Europe, Middle East, Asia, Australia, South America, and the US, should have a website where they themselves talk about what is in their mind about what and how they look at breast implant illness. They should talk openly and say, this is how I do it, why I do it, and the manner. This is what my goal of the surgery is. This is part of the informed consent. Because that way, you can not only hear the patients, but most importantly, hear the surgeon. Now, I will tell you, when I talk to my patients, I don't have my nurse or my PA or my nurse practitioner or anyone talking about them, because I myself talk to the patients because I want to hear directly before, during, and after. So I'm very much hands on board. Now, when the patients come to me, they are not only well informed and read, they're actually very excited about their surgery. So when they do come, I want to see them not the morning off, at least the day before. So number one. Number two, the day before, you get all your questions answered. Ideally, if you want to, come here and see me and talk to me. I can examine you, and so that you feel comfortable about what you're signing up for. Believe it or not, there are many patients who even sign up for the surgery and pay without even talking to me because they have heard other patients talk about their surgical experience with me. So it is important for a surgeon, for her own good, to be very transparent, especially when it comes to the explant surgery, so that he can and she can share his or her own views. And not only that, but to share the pictures and videos of the chest wall showing complete removal. Because remember, one free soldier is better than 10 hired ones, which means if the surgeon is doing it from their heart,
Yes.
versus someone you're paying, do it, and it's like, okay, I will try, let me see what I will find. No, you don't want to go to a surgeon because it should come. Some patients came to me and said, I don't want my capsule removed. Then I said, I'm not your surgeon because I don't want to do disservice to them.
Yeah.
Now, going back to your point, the patients then come to me on Monday in clinic. I talk to them, I see them, I give them the scripts for the medications. Tuesday, the surgery occurs, and then they recover Tuesday, Wednesday, Thursday. Now, Friday, I then see them in clinic, and I will tell you, as far as I'm concerned, remember, we learn a whole lot more on the day of the surgery itself. And then the patients have 3 days to essentially declare themselves how they are, how they're feeling, how their symptoms are. And remember, they then meet criteria to be heading back home. Now, because they came international, I will say to them, now remember, it is a flight that's anywhere from 8 to 9 hours away, 7, 8, 9 hours away. So it's not that far. If you come from California, believe it or not, it's a 5.5 hour flight,
Okay.
5 hour flight. So it's pretty much equidistant, if you will. Now, I will say this to you, once you head back to Europe or wherever, you will have the peace of mind that you have had 3 days to declare yourself. And remember, you see me in the recovery, you see me in the post-op visit, and this is where I give you the green light. And I'll tell you, except for maybe 3 patients, I have not kept them over. There was a patient that came to me with 800 cc implant on prednisone, and she was in her mid-50s, and they were videotaping her. I wanted her to stay the extra. And so that was the one patient. The other 2 patients themselves said, we want to stay here just in case, so we have the peace of mind. And I said, it's perfectly fine, which only they ended up going back and there was no reason. So once you are heading back, again, it is relatively speaking very well tolerated surgery. The patients that have come to me from Egypt, Germany, Japan, from Jamaica, from New Zealand, from Germany, the patient that we are talking about, they ended up staying a few days extra, a week extra, just so that they would have the peace of mind, such that when they do go back, they will not be requiring any intervention or anything of that sort.
Do they have, if someone comes from another country, do they have a video consultation before, or is it just that personal appointment one day before surgery you were talking about?
No. I always do a phone consultation. I always talk to them. I ask from the pictures if needed. I always do a phone consultation. So anyone who has had a phone consult with me, I always tell them that this is not the one and only time. If you ever need to get a hold of me, you text me, and we will reconvene again for a second time and a third time. Because remember, this is a big deal, and the patients must feel very comfortable, confident moving on. Because remember, you read another day, and after some time, you may have another question. So I always tell them 3 things. If you have a question that cannot wait for me, text me again, and I'm very good about talking to them. Believe it or not, I have 3 phones, and I'm very much hands-on with my patients, as you will see. So if there are questions that they need an immediate answer to, I talk to them. If they can wait for me till they see me in person in my clinic, then I tell them I will answer the questions in person. Or if they have any technical non-MD questions, I tell them, please talk to Marlena or Sally, and they'll be able to answer any non-MD, any technical questions that may have.
Okay. And besides that, I'm sure they get a checklist with recommendations before and after surgery concerning medication, compressions, bra, movements of the body, and so on. Do you have any checklists?
Yes,
for
absolutely.
Your patients?
Yes, absolutely.
Okay.
Yes. So they go, and we have it on our website as well. What to do the day before, what are the instructions, the discharge instructions. That's what I did talk to them the day before, or the Friday before, if they do come from international, because you don't want to see me the day before if you're coming from an international flight, be it delayed. So sometimes I see them on that Friday or on that Monday.
Okay.
And so that they are very comfortable. And as you will see, this is relatively speaking very standardized, meaning from one patient to the next.
Okay. Thank you. So my very last question for you today, Dr. Khan, is do you think breast implants should be banned from the market?
So I will tell you my take-home message in my practice and what I specifically chose. Remember, when I got done with my training, and this was 10 years, you're in a lot of debt, financial. And this is where it's very easy in 1 hour to put in implants. And it's very financially rewarding. I chose not to do so. And I'll tell you, I felt the hurt in a way working out of the emergency room and taking care of reconstructive patients, because I said to myself, I'm going to put my foot down and I'm not going to augment. Now, if you look at my practice 10 years ago, there was not even much of a mention of breast implant illness, not even an awareness, not even a discussion, not even in the news. If you look at where we are in 2024, you will see there is not a single plastic surgeon in the United States that I can think of who does not have the word explant, breast implant illness, capsulectomy, or their webpage catering to these patients who are interested in getting an explant. You follow what I'm saying? Meaning it has been overwhelmingly accepted. Now, the goal here is the implants have been banned. They've been associated. Number 2, they are not lifetime devices.
Yeah.
They have been banned in 1992 to 2007. They are not lifetime devices. Quote, the longer you have them, the higher the chances you're going to require a reoperation. Number four, they're associated with questionable infection, biofilm, and inactive infections that can spontaneously occur even years and months later. Acute and chronic pain, capsular contracture, malposition, the BIALCL, the BIASCC, obscuring breast cancer. Remember the self. I just saw this very last patient. She has grade 3 contracture, hardened breast tissue, and implant on the right side. Her breast exam is very limited because she cannot palpate her breast tissue, and her sensation is lost as a result of the contracture. Now she's not going to be able to do a good optimal self-monthly breast exam. And those patients that have grade 3 and grade 4 contracture, which means pain, and now you're not able to wanting to do a mammogram because you're afraid that it's painful or it may cause a rupture. And then you will see in a young lady who's 22, for example, and in her lifetime, every 10 years or 15 years, if she were to get a replacement, she's going to at least change this 6 times, let alone all the problems in the middle, right?
Yeah.
Why do something that has so much loss and so little gain and benefit? Yes, I will not know what it is to have breast tissue or an implant, but I will tell you, knowing what I know, it is something that I would advise the patients against. Now, if I could, knowing the bad and the uncertainty that we live in, I wouldn't recommend it because I didn't even want to do it as part and scope of my practice and do no harm. Some implants that I have removed in my practice, as you have seen in the Facebook Live and YouTube Live from 2016 in a 33-year-old with both ruptures. Who wants to be with that, right? Who wants to be living with potential infections, acute and chronic? Remember, we're very rare. Remember, lymphoma is extremely rare, but it's underreported, like I mentioned earlier. And the take-home message is do no harm. Don't, I use the word, insult the body in a manner where ultimately, when you look back, most of my patients, if not all, say two things. They wish they had not gotten implants and they wish they had removed them sooner. And you don't want to wait for a bigger fire, for a rupture to occur before you do something, rather than take care of it preemptively. And I say to because of what I know and what I have seen and in my practice, and I invite plastic surgeons, the FDA, anyone, to see firsthand how the patients are hurting one after another. If I could, I would take the initiative in my own hand. I would ban them the next second because they are not worth it. They cannot be justified. And I will tell you, they only cause harm. No one walks into my clinic and says, while my implants are making me think sharper, better, I have better joint function, I can ride my bike faster. If anything, it's only badness, right? The autoimmune problems, the anxiety, depression. And these are patients from all walks of life. Implants that ladies have had from the 80s, 90s, 2000, and the newer cohesive implants are not safe. They are the same set of problems that those previous implants had. There is nothing gummy bear about them. There is nothing cohesive about them. They cause the same disintegration that these older implants. And very soon, unfortunately, the patients are going to be talking about it so much, including the celebrities, that the FDA and the medical society will have no choice but to step up and ban them. And it is smarter to ban them now rather than promote them and to encourage them, especially in the young ladies who truly are clueless about the hurt that these implants cause.
Yeah, I totally agree with you in this, Dr. Khan. Totally. Yeah, and that's what I'm working for with my organization. So, okay, I want to say thank you again. Thank you so much for your time and for sharing your knowledge with me and for us in Germany. I feel honored that you took your time for me and for us. Your webpage can be found on my website in the category Plastic Surgeons, of course. And I want to say thank you and have a nice day, Dr. Khan. And
Thank you. Thank you. I want to
yeah.
mention to you, and this is what I mentioned before we started the recording. I
Mm-hmm.
invite you in the next couple of months.
Mm-hmm.
Please come back as a Facebook guest live or YouTube
Mm-hmm.
live, whatever, however you can arrange,
Mm-hmm.
so that I can answer any of your listeners' questions directly. So I
Yeah.
can go into the details. We can start off by an initial presentation. This was very good. And
Mm-hmm.
then I can take maybe 5, 10 callers, listeners who
Mm-hmm.
may have questions. You can bring them online. I can answer
Yeah.
questions, and we can do this.
Mm-hmm.
Remember, the patients in the U.S. are as human as the patients in the Europe. And
Absolutely.
we in South America, we're the
Yeah.
same gallbladder, the same
Yes.
thyroid, and the same uterus, and the same breast, and it's
Yes.
the same physiology. It affects us whole as one system,
Yeah.
and the pathology is essentially the same. There are parts of the Middle East that have not even heard this yet, or South
Mm.
America, and this is where we need to raise awareness so
Yes.
that the patients. And today's goal was not for the patients to read a conclusion. This
Mm.
is for the patients to reach a educated, informed decision making
Yes.
capacity so that they understand if this is what the hurt is, they can deal
Mm.
with the situation rather
Yeah.
than going to the subspecialist and getting started on other
Yeah.
strong medications to suppress the immune system. So,
Yeah.
this is a good, healthy start. So, you can learn more about this from your channel, from my channel, and
Mm-hmm.
then you can make a rational decision.
Yeah, that's right. Absolutely. So thank you for that offer. We will find an appointment to do
Yes.
a Facebook Live. Okay, so thank you again and have a nice day, Dr. Khan. Bye bye.
You're
Thank
welcome.
you.
You're welcome. Take care. My pleasure. Take care. Thank you. Bye
Thank
bye.
you. Bye.